let's get this show on the road because we're probably all trying to prepare for Thanksgiving. Who am I kidding? I'm not preparing for Thanksgiving. This is Dr. Garais, and let's see, anything in the chat. You are very welcome, Ms. Vargas. Now, it is 9 a.m., week 7, November 25. Again, a public service announcement. In theory, there is no school Thursday or Friday, but like I told the laboratory last week, it's just another shift. Most of the medical personnel are working this week, but that's life. But there will be, if you have a Thursday or Friday class, there shouldn't be any live or synchronous sessions. The same for my classes, but I'm also going to put it out there for the people who missed last week's laboratory. If you could confirm that you're coming to the makeup that's in your announcements here, or if you would like to come into another lab or another class, just give me a call. I think I may be having a weekend Saturday session, depending on some feedback I'm waiting on some of my Friday classes, because nobody went to my Friday labs last week. I think one person went to lab on Friday. And if you're in a clinical slash laboratory class, labs, you pay for that. So if you miss it, you don't get your money back. So please try not to miss those, or if you do miss them, try to get the lab, because that's where you really learn things. And if it's a clinical laboratory, that's really, you won't know what you're doing in the real world, and that's a shame.
Good morning,
So,
Professor.
good morning, welcome. So what was I doing? Let's go. What's due this week is task 6, discussion 6, lesson 6, because this is now week 7. We're going to try to, yes, I believe December 8th. Let's go look to just check, since I'm in public service announcement mode. So you go into the announcements, you go into your laboratory dates, and here's the laboratory dates, because your class typically meets on Wednesday. So we had 18th was the first session. You come in on December 2nd. That's the second session. We don't go backwards. We just do what this is. But if you schedule for the makeup, you do whatever you missed. And if you missed more than one, you and I have to talk offline. Let's see what questions came up. Yeah, December 2 is the next one, and December 9 is a 9 a.m. makeup. But I'm also going to be on campus on random Saturdays, because I also have tutoring, and it's mainly for my Friday class. So because that's a clinical class, 3 hours is not 3 hours on 2 sessions, 6 hours total to learn clinical skill sets is not enough. So some of them have to come in on Saturday. Because my adage is, if you don't get it down in lab, come back again. And you paid for it. So these are the posted dates for your class. Please try, like when you try to get makeups, please don't show up to a class, because if you show up to my my clinical class, it's going to be very hard to proctor your dissection and do the clinical class at the same time. So when you come in, please try to adhere to the dates here stated. Let us now go back to week 7. Now, by the end of week 9, we're trying to wrap up everything by week 9. because there were several students at the beginning of the term stating that they're going to be I'm going on vacation, or they have work issues because it's so close to the holidays. So our goal is to try to wrap up everything by week 9 and have your final exam ready for you by week 9. That's our goal. But we have week 10, available as well. Okay. And by next week, I'll be, of course, having the lecture, but I'll post another video lecture of a quick review, and also, just like your midterm, I'm going to put out last term's final exam, so you can get to know what it looks like. So, what are we doing this week? This is week 7. The topic is respiratory. So, of course, you got some videos you could watch here. We're going to be looking, you have Carolina notes right here, and task 7. These are very nice. If you look at them, they have a nice synopsis, okay, of the same items that we'll go over in your textbook. And let's see. So here are your 3 tasks, and I was having tutoring earlier this week, and if you're having trouble doing concept map or trying to study or trying to figure out what's important, you always go to your concept map, their tasks. So let's pretend like I'm a student, I'm all alone, and I haven't watched the videos yet. So I'm looking at the structure, and then and also what is gas exchange, and oxygen and carbon dioxide, how do they go in and out of my lungs? So with those 3 main questions, I can go into my textbook and answer them. Now remember, if you have trouble sleeping, read the textbook from cover to cover. It's very easy to fall asleep. But the way to really use a textbook is to have an objective, which we already have, and then meet that objective just by answering and looking for answers. So the muscular system, nervous, somatic, autonomic nervous, neurologic, endocrine, cardiovascular should be coming up. Cardiovascular, lymphatic, and immune. Here you go, respiratory. So respiratory is chapter 22. And if you look at here, introduction, doesn't it give me the structures, the things that I need to know? And gas exchange, how do I actually breathe? So 22.3 and 22.4 and 22.5 meet the criteria of one of our objectives, right? Now, was embryonic development part of what we had to do? No, so I'm not going to look at that. Modifications in respiratory function, do I have to look at that? No. But these things right here, I have to look at it because they were part of my objectives. So I'm looking at my objectives. So I need to know all the players in the respiratory system. So we look at this, and could this easily be a question on the exam? Because it is an anatomy exam. So I could erase all of these, in Microsoft Paint, and then just put A, B, C, D, E, F, G. So let's look at this. So the respiratory system, the function of the respiratory system, its main function, we already ascertained from the objectives. It's gas exchange. I need oxygen, and we already know why we need oxygen. Oxygen combined with glucose makes ATP. ATP is the molecular fuel that powers this machine right here, this human being. So I need to be able to breathe. And how do I breathe? I breathe through my nose and I breathe through my mouth. So it goes through the nasal cavity and the oral cavity, which is part of this respiratory system. Because if anything blocks this stuff up here, when you get a stuffy nose or rhinitis, it's hard time breathing and you get tired, you get weak. Here's your pharynx, which is part of your throat. Your larynx, which is some cartilaginous material here, which is your voice box. Then you have the C-shaped trachea. There's cartilaginous rings, and they continue on to your right and left main stem bronchus, and then into your lungs. And you have a right lung and a left lung. And we're going to talk a little bit more detail. And we're also going to talk about how you breathe. And one of the muscles of respiration, or how you breathe, is your diaphragm, which is a thin strip of muscle right here underneath your lungs. So right off the bat, you will see that there are upper respiratory parts and there are lower respiratory parts. The lower respiratory tract starts at the trachea on down. So your trachea, your right and left main stem bronchus, and your lungs, that's lower respiratory tract. Everything above your trachea, that's upper respiratory tract. So when someone has, I mentioned rhinitis, you know, you have a cold or inflammation or infection of your nasal cavity, right? Maybe a little bit of a postnasal drip. That's an upper respiratory tract infection. You have pharyngitis, which is a sore throat. That's upper respiratory tract infection. You lose your voice a little bit because of you got hoarseness in your throat. That's laryngitis, right? You lose your voice a little bit because your larynx is your voice box. So those are upper respiratory tract infections. You could even have maybe some dental problems and some oral cavity infections, but that's all upper respiratory tract infection. URTI is not a dangerous thing. What's dangerous is that, remember we discussed progression of pathology or pathophysiology. If the upper respiratory tract infection is unchecked, it will go down here into your lungs, okay? So, and especially in an immunocompromised person. And once you're already sick and you don't take care of yourself, you're going to be immunocompromised, and whatever's up here is going to end up down here. And down here is bad news. So if you have tracheitis, if you have pneumonia, bronchitis, emphysema, and we're going to be talking about the pathophysiology really briefly later on in this lecture, that's bad news. You get to go to the hospital for all of those lower respiratory tract infections. Okay, so you have the upper, you have the lower. Be able to distinguish between the two, and that helps suffice our first objective, which is what is the structure? What is goes? Who are my key players in the respiratory function? Now you'll see there's a conduction zone, and in medicine they call all this your bronchus and all the way up to your nose. They call that the dead zone. They call it the dead zone because there's no gas exchange happening up there. The gas exchange happens in the lungs, and we're going to look a little bit closer of what happens and what goes on in the lungs. And remember, what gases are we exchanging? I am taking in oxygen because I need that for fuel, and I'm getting rid of the byproduct, which is carbon dioxide, which is our waste. So when you breathe in, you're breathing in oxygen and exchanging it for your body's waste, which is carbon dioxide, and hence the term gas exchange. Okay. Here's your nose. Your nose has cartilage because we want to keep, you know, it can't be rigid, but we want to keep the nares, which are the openings, Nares, and it's pronounced nares, and you have two of them separated by your septum. So when these things close up, or if you have a deviated septum, you're going to have a really serious snoring problem, and you might have some sleep apnea, a whole bunch of pathologies that will lead to also poor sleep. You could see here, let's look at this a little bit closely. Your nasal passages are nice and open, and they have these pathways. And remember, any opening is called the meatus, and you have a superior, middle, and inferior, and the nasal conchae, which is there's like these shelves and they kind of look like a shell. That's why they call them a conch. And you could see how close your brain is. Your brain is up here, and there's nerves here. So we'll be talking about that in future lectures in anatomy and physiology too. On there's a whole bunch of nerves here for smell, and this is also the reason why you snort cocaine. Well, you shouldn't snort cocaine, but if you do, now you know exactly how it works. All the magic dust goes in here. It it latches on to all these nerves up here, and it gets you high immediately. And then you have this erosion of your ethmoid bone, and also there's blood vessels here, and that's why they get nosebleeds. You could see here your tongue, and you have your hard palate and your soft palate. And all this has to be patent or open so that you can breathe. You have back here the posterior tube, that is your esophagus or food tube. And you have your epiglottis right here, which protects your trachea here, right after it goes to the thyroid and all this cartilage here. Your trachea connects down here. So the function of your epiglottis is when you drink or when you eat, that keeps it closed, because when you're drinking or eating, you shouldn't be talking. You actually kind of hold your breath a little bit when you're drinking or eating. But you know what happens if you try to talk when you're swallowing some water, you'll choke a little bit because you don't want anything there. Now, here is a nice, beautiful picture. And remember we talked about in lab form and function, you could see this little thing. It's hard to, you got to use your imagination a little bit. Columnar cells, don't they look like tubes? And what I remember is like tube of toothpaste. It's got to have something in it. Well, you have goblet cells, and they release mucus. And that's really important because in the pseudostratified columnar epithelial of your respiratory tract, there is a layer of mucus. And we already know that that layer is very important for our frontline immune response. And the cilia, which is these little tiny hairs here, they help move that dirty mucus with all the dust, debris, and it even can capture some viruses, and it moves it on down. And that's why when you sneeze or you cough up something, you should really cough it up into a tissue and then throw it out. And they call it pseudostratified because it's not really stratified neatly in a row. It's all different rows. But the main takeaway from this picture is goblet cells make mucus. Mucus traps all foreign body viruses and other potential harmful pathologic items. And then the cilia, these little tiny little finger-like or hair-like projections, then move it up or down the respiratory tract. So that is one form of immune response. Hard, soft palate, we already went over that. Here is here's another view. Let's make this a little bigger. Here's another view of your larynx, which is made up of cartilage. Your larynx is behind here, and then of course you have thyroid cartilage, which then right on top of it houses your thyroid gland. And here's your epiglottis, which is the flap that protects your respiratory tract when you are eating or drinking. Here are vocal folds, and they're made out of cartilage. And remember, the cartilage isn't really hard like bone, but it's comprised almost of the same things as bone, but with less calcium and less magnesium phosphates. So it's pliable like a rubber band. And when we breathe or speak, it vibrates these vocal cords, and that's how you have phonation or speech and sounds. And of course, the more air you put through it, the louder it can be, and the less air you put through it, the softer it'll be. Now let's look at the trachea. You have your larynx, and then now this is the beginning of your lower respiratory tract. Now your trachea is covered by cartilaginous rings. The cartilage is only in the front, so it's C-shaped. So, and it makes sense because, let's go back to that picture earlier. It makes sense because if I had cartilage that went all the way around, it would bind up the esophagus. And the esophagus has to be flexible because depending on how much food I eat. So if I ate like, you know, a big bite of my, what do I want to eat today? Of my hamburger bite from 7-Eleven, it's going to create a bolus or this big thing here. And if you had cartilage that went all the way around, it would impinge and it would narrow the esophagus. Instead, whoever built us really smart. They wanted to protect your trachea, but only in the front. And in the back, there's no real protection because so that the esophagus can expand when we eat food. Okay, so C-shaped cartilaginous rings. Now, as you get deeper and deeper into your lungs, it becomes less and less cartilage and more smooth muscle. And as we recall, smooth muscle cannot be controlled. That is involuntary or visceral muscle. So these cartilaginous rings give way. This is your right main stem bronchus and your left main stem bronchus. And this picture isn't that good, but in theory, your right stem bronchus, this one, is shorter and more vertically aligned. That means if any foreign body falls into your lungs, the odds of it affecting the right lung is greater than the left. And then these are bronchioles, which then they get smaller and smaller and smaller as you progress deeper into the lung. And you could see how that could be a detriment. For example, if I have foreign body like coal dust or asbestos, it falls in here and then it'll get entrapped in here. And then there's going to be a very bad immune response inside your lung. And that's the reason why when, let's say you enter a really, really dusty or dirty room, you kind of like gag reflex and you cough, and you also have a cough reflex. So to get rid of any foreign body that's that just happened to get inside your respiratory system, because this has to be clear to breathe. Oh yeah, this area right here, when the main stem bronchi split from the trachea, is called your carina. How am I getting updates? I don't want updates. Okay. And this is called the bronchial tree because it kind of looks like a tree and it gets branches and gets smaller and smaller and smaller. Now, what does it end up as? At the ends of the bronchioles, also known as your terminal bronchiole, at the very end, you have these sacs, and they're called alveoli. Alveoli is plural, and alveoli, the derivative of that word means bunches of grapes in Latin. So you have these air sacs, and they're bunches of grapes at the end of the bronchioles. And you can see here, there is no cartilage at these terminal bronchioles. It's only smooth muscle. And we're going to talk, it goes, and we're going to talk about asthmatics in a moment. And if my smooth muscle, and remember, I can't control this. If my smooth muscle starts squeezing on this, I won't be able to breathe. You could also see here where the alveoli, there's a lot of capillaries. And remember, capillaries are the vessels that join the arterioles and the venules. And they're very, very thin and they're very, very small. And it makes sense because this is the point of gas exchange. That's why everything above it is also called the non-conducting zone or dead zone. This is the star of the show right here in your lungs, your alveoli. You got hundreds of thousands of them in both of your lungs, and that's where we're going to have gas exchange. But you could see if there's too much mucus, there's going to be a problem. Gas won't go in and out. If you have pneumonia where all this is underwater, that's not good either. Your lungs should be moist. They shouldn't be dry, nor should they be wet or drowning in water. And that's essentially what pneumonia is. And like I mentioned earlier here with asthmatics, right? They detect foreign body and they're very, very sensitive. And the smooth muscle will start squeezing on this. And then my patient's going to have dyspnea or a really bad time breathing. So I could ask, what are at the end of the terminal bronchioles? Is it cartilage or smooth muscle? And you'll remember this picture, smooth muscle. The alveoli sacs, what are they lined with? They're all lined with vasculature. And the main part is all these pulmonary capillaries, which is the location of gas exchange. That means we take in oxygen here and we get rid of carbon dioxide. So I take in oxygen and then I oxygenate these arterioles. And then these venules have tons of carbon dioxide, and I'm running out of air myself. These venules have a lot of carbon dioxide, and then they want to get rid of it. And we're going to show you exactly how momentarily. So, and you could even look, just like we talked about in lab, if we look at its structure, right, of the alveoli and its microscopy and its morphology, you could see that they're sacs, and they're sacs to be filled with air, and they're thin, and they're so thin, you can see here that oxygen and carbon dioxide, it's barely one cell thick that can go in and out. Okay. Now, what are these alveolar cells lined with? They're also lined with macrophages. And remember we talked about macrophages before? Macrophages are thugs. They're just macro meaning big, phage meaning eat. Their function is just to eat any foreign body that gets into our lungs. And you also have type 1 and type 2 alveolar cells. And the type 1 cells make this stuff called surfactant. Now, surfactant is really important because that is what gives your lungs the ability for gas exchange. And it also reduces the surface tension. Remember, right here, right? There's a surface tension. And how do we know? Anytime you have any water, put a bead of water on a table, right? You know, on your kitchen table. You'll see it forms like a bubble and forms like a skin. Well, surfactant kind of makes that skin thinner and easy for gas exchange to go on here. And surfactant and type 2 alveolar cells are what we measure in premature babies, because if you're a preemie like me, I was born around 30 weeks age of gestation. I didn't have any of this. So when I was born, my lungs weren't working right. So they had to hook me up to a mechanical ventilator, because without surfactant, you don't have reduction of surface tension, and your oxygen and carbon dioxide won't go through your alveolar cell wall very well. So remember that, surfactant. Okay, here's like a diagrammatic version of what we were looking at before, and you could see there's a thin line of mucus, and that's normal. But what happens when the goblet cells get out of control, like when you get sick, you get a large amount of mucus. Now, can things go in and out when there's a large, thick film of mucus? No. So too much of a good thing becomes a bad thing. I also don't want to take Mucinex to strip all of that, because if I take Mucinex all day, a mucolytic, I won't have anything stopping any of those pathologies, right? Those pathologic, the 249 things floating around in the air that could kill me. I don't want them to have the ability to go in and out of here very easy. And that is a very important function of mucus. It traps foreign body. It traps even viruses. So when you have asthma, that's another thing you have a lot of. Asthma is essentially an autoimmune disease in disguise. Like, for example, if I blow dust in your face and you're non-asthmatic, you'll just cough up, right? You'll wipe your nose and and cough a little bit and say to me, hey, what's the problem? But if you're an asthmatic, that little bit of dust will then trigger a whole bunch of things. And one of those things is an exaggerated immune response. That means you're going to have way too much mucus. And what's going to happen to all those smooth muscles that we talked about here? All these smooth muscles will now start to constrict. And remember, you don't really have any control over that. It's your brain that has control over that. So if your brain is sensing that your lungs are being attacked by that little itty bit of dust, this will start to close up. And that's what happens in an asthmatic patient. That's why we give the asthmatic bronchodilators to open up your bronchus. We also give my patient corticosteroids to decrease their immune response. But you guys know, if I have a lot of cortisol or corticosteroids, I am also predisposing my patient to other pathogens. And back to my conspiracy theories on COVID. Hey, that's funny. Then goes, if COVID really has a super serious pneumonia killing predilection for the lungs, then why aren't asthmatic and bronchitis and emphysema patients getting hit way more than normal people? Something to think about. I've been looking up those statistics since March. There's no significant increase for any pulmonary patients for COVID, which is interesting because we already know that that particular virus loves the lungs. And that's why any viral pneumonia with COVID is deadly. But fortunately for the world, it is relatively rare. Because again, I've mentioned this in multiple lectures. I am unsure of the diagnostic criteria of COVID, and until people start defining it, and they'll probably define it long after the threat is gone. So back to stuff, or we're going to be here all day. Because you start me on my conspiracy theories, I could do that all day. So let's look at the lungs itself. Now the lungs, once we start cutting up the pigs on our next laboratory, we're going to be doing full pig. When we start doing at respiratory, you'll notice that the lungs are spongy. It's got a lot, and also has these sections. And whoever built us perfect, because the sections can sequester bad things like infection or cancers. So they have rooms or lobes. So your right lung, right here, and this is a better picture of your right mainstem bronchus. See how it's like almost directly, like if a pebble were to fall down here, you could see how it's easier to fall here in the right lung. So the right lung has a superior lobe, middle lobe, and inferior lobe. And the left lung has a superior lobe and inferior lobe. It has no middle lobe. But what the left lung has is right here, a cardiac notch. And that is where your heart sits, right in there. Because remember, your heart and lungs are cousins. Because if one starts to fail, the other one will fail. Okay, if you start having lung problems, you'll have a right-sided heart failure as an eventuality. If your heart cannot get oxygen, not pump oxygen through your blood to where it needs to go, then all the work that the lungs will do is moot or useless. Blood supply, you got your pulmonary veins. We already know that from what do you call that? From cardiovascular, that your pulmonary artery, pulmonary veins, and your mainstem bronchus go through this portal called your hilum. So let's see if they have a picture of it. Let me just find one, be quicker. Here is a nice one. So inside the side of your lungs, and this is a beautiful question. Maybe this is better. Okay. Inside the side of your lungs. Whoa, whoa, what is going on there? Inside the inside part of your lungs, this is the hilum, or the section where your main stem bronchus, your pulmonary artery, and pulmonary veins go in. Now remember, if you recall the box diagram of cardiovascular, the the pulmonary circulation is kind of backwards. Typically, arteries are oxygenated, but in our case, the artery, the pulmonary artery leaving the right side of your lung is deoxygenated because it's leaving the heart so it can be oxygenated by the lungs, and then it goes back to the heart via the pulmonary veins. So you're going to have like four connections, two from each um, um, lung that go into the posterior portion of your heart. And it makes sense because after I need to reoxygenate my lungs, and I also need to get all that carbon dioxide into my lungs so I can breathe it back out. So a beautiful question is, what are the structures within the hilum? And you could tell me: main stem bronchus, pulmonary artery, pulmonary vein. Another question would be: pulmonary artery, is it oxygenated, deoxygenated, both, or neither? In pulmonary artery, it's colored blue here. That means it's deoxygenated. Your pulmonary vein is oxygenated. Okay. Uh, da, 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 da. Let's now talk about the covering of your lungs, or also known as your pleura. Next week, when we do dissection, when we open up the lungs, right? You could see that there's two coverings. You have your parietal pleura and your visceral pleura. This is how I remember the viscera, because viscera means guts. So that has to be the one on the inside. And the parietal pleura, it's got to be the one on the outside. Now, what's in between? What's in between is a potential space, just like the pericardium of your heart. And there's some fluid in there. And that helps the lungs. It lubricates the lungs because all day, every day, your lung is expanding and shrinking, expanding and shrinking. And this pleura and pleural fluid are quietly lubricating your lungs. And the only time you'll notice it, if you'll get pleurisy, which is, when you get a bad cough and it feels like a knife running up and down your manubrium sternum here, that's because this got infected. And also, if you get air in there or blood in there, that'll start compressing on your lungs, and then you're going to have a really hard time breathing. So your pleura is the covering of both your lungs. You have two sections of it. You have the viscera, which is on the inside, and the parietal, which is on the outside. And what's in the middle is a potential space that has some pleural fluid in there. Okay. And again, you can't have too much fluid, but you can't have too little fluid. It has to be just right. So how do we breathe? Okay. This is Boyle's law. You eventually need to know this, but just know that what Boyle's law comes down to goes as pressure increases, right? The volume would increase. And if the as it goes, as the volume increases, like if I open up my lungs, pressure decreases. And if if the volume decreases, right, it gets compressed. Of course, the pressure, which is the force exerted upon the walls, get increased. And you can see it makes sense, right? So the more gas I have in a system and the more I compress it, like in my lungs, the increased pressure I have. Now, the best way to look at it is like this. When let's draw it, because I like drawing it. Let's draw, and I'm going to draw a person here with lungs, like my picture. It's very artistic. Okay. And out here is the atmosphere, right? You know, right here is the atmosphere. And of course, your lungs. I'm going to draw two boxes. It's good that I went to medical school. That art is not my thing. Now, what happens when you inhale? Inhalation. Wow, that's ugly, but you guys get it. Inhale. So when I inhale, remember my diaphragm, that thin muscle that was underneath my lungs? That thing is going to go down. And what will it do? We just talked about pressure. It goes, if I increase the volume, it's going to decrease the pressure. So it's going to make a negative pressure inside my lungs. Negative. So I have a negative pressure in my lungs, and the atmospheric pressure is positive. Let me put a positive pressure. Now, we already know about, remember diffusion? Everything goes from a higher concentration to a lower concentration, especially gas. So when my diaphragm bottoms out like this, it creates a negative pressure in my lungs, and then what will happen? Air will go in. And if air goes in, that's inhalation. Now, what happens when I max out my pressure, and now the pressure in my lungs is greater? So now I have a greater positive pressure. I'll draw more positives here. Right, these are my lungs. So if I have now positive pressure, it's going to be greater than the pressure that's outside here. What's going to happen? I am going to exhale. Oh, why is it so difficult? How's this? Insert, text box, put it here. Oh, why won't it insert in the text box? Draw text box. Exhale. So let's review that. First thing that my diaphragm does is bottom out. It creates a negative pressure in my lungs. The negative pressure is much smaller or less than the positive pressure here in the atmosphere. Therefore, I will inhale. And then you inhale, you get to the point where there's a buildup of pressure all the way on the inside of your lungs, right? More pluses. And then what's going to happen? You're eventually going to exhale. Now, what am I taking in my air? I'm trying to take in oxygen. And then what am I getting rid of when I exhale? Because I'm trying to get rid of carbon dioxide. Okay? So what kind of questions could I ask? I could ask, how do you inhale? What muscle do we require? Diaphragm. I could ask, where's the greater pressure, atmosphere or your lungs? Upon inhalation, the atmosphere is the greater pressure. That's why you inhale. Upon exhalation, where's the greater pressure? The greater pressure is on the lungs and greater than the atmosphere. Therefore, I will exhale. Now, this is all a closed system. So you can only imagine what would happen, right? Johnny Box here. I took a knife and I poked a hole in here. Now you have no more pressure gradient. If there's no more pressure gradient, my patient no longer can breathe. So gunshot wound, if I stab my patient here, if I put a hole anywhere in the chest wall, right? and that's why we have a rib cage to protect us, my patient will have a lot of difficulty breathing. Okay, and this is how exactly you breathe. So now you know why you, like how you physiologically breathe. Now, here's also the answer to the question why. So why are you breathing? Because your body is detecting that that you have way too much carbon dioxide. And who detects that? It's your spinal cord and your cerebrospinal fluid. And then it sends a message to your brain, hey, I think you should start breathing because the carbon dioxide is starting to build in your body and you got to get rid of it. Okay? So it is not oxygen that your body monitors. It's carbon dioxide. That's what your body monitors for breathing. Okay. Force equals pressure resistance, pulmonary. Oh, I did all my awesome picture when there was an awesome picture right here, and you can see here. Well, now, what are some of the other muscles of respiration? You also have your intercostal muscles as well. Now, there's a reason why your chest wall or your rib cage has cartilage on it, because this has to have the ability to expand. So when you inhale or inspire, your chest wall will expand, right? And your diaphragm will bottom out, and then greater pressure out here, lesser pressure in here, because this is now a negative pressure, and things go in. And in the exact opposite, things go out. Okay. Here's some volumes. You get to look at this more in your pathology class, but let's go. You got to know these volumes, not for my exam, but many of you are future nurses. There's a lot of questions on the NCLEX regarding, not a lot, but there's a decent amount of questions regarding lung volumes. And what are these lung volumes? They can be measured by two things. We measure lung volume utilizing spirometer. Now, the tidal volume is where you normally breathe. And then you have volume that you can expire, that's all the way to your max, which is your expiratory reserve. And then beyond that, you got about a liter more in your lung that you can't really get rid of. Then you also have an inspiratory reserve. Now, you got to know kind of like the math. So for example, vital capacity equals expiratory plus tidal plus inspiratory, and then the residual volume. Total lung capacity is what? All the lung capacities all together, and they can be anywhere from 5 to 6 liters in a typical 70-kilogram patient. And inspiratory capacity is tidal volume plus IRV, which is inspiratory reserve volume. And functional residual capacity is your expiratory reserve volume plus residual. So if you know this, answering the math questions that are on your NCLEX, like they'll say something like, if my patient has a tidal volume of 500 cc's and like 3,500 cc's of IRV, what is the total lung capacity of your patient? Or what's the inspiratory capacity? And then, you know, you answer it that way. But you could see how they line up. So inspiratory capacity are these two things. Functional or FRC is this. Your total lung capacity is everything. Vital capacity is this plus this. Residual is, of course, the extra liter that's left in your lung after you expel everything. Okay? But this is nice to know. I'm not going to ask this. I may have one question on it on your final, but the other stuff that we talked about is a little bit more important. But definitely know this if for your future NCLEX desires and goals. Now, what are the ventilation control centers? Just know that the the main gas that your body is monitoring is carbon dioxide, or the PCO2. And P means partial pressure. That means the pressure within that carbon dioxide gas is exerting in your arteries and veins, more your veins than your arteries. And also, your body also monitors pH, the amount of if something's acid or base. And this is the big thing for nursing, is that for future nursing, and for anyone interested in pulmonary physiology, arterial blood gas, which is the second test, tests these three things: carbon dioxide, oxygen, and pH. So when we do an ABG, that gives us these numbers, which we can now look at to look at our respiratory status of our patient, and also the acid-base status of our patient. And you could see here, in anatomy physiology 2, we're going to be talking about like all the really serious and important parts of your brain are deep. So this is your brain, this is your cortex, and this is your brainstem. And you could see all the stuff regarding breathing is all the way inside here, right? And it's called your PRG, or your pontine respiratory group, and your DRG, which is dorsal respiratory group. So you could see here that it's deep in your brain. So it goes, I could still, people who try to kill themselves, you could put a pistol to your head, blow this part out, you will still be breathing. You could fly out of a car and all of this can get damaged and be left on the road, but you will still be breathing. So whoever created us put our vital functions in a nice, deep, and safe place. But if you have a basal skull fracture, which is down here, how much trouble you're in. If you have a spinal cord injury here, especially in your higher cervical area, how much trouble are you in, right? So just know that the VRG, DRG, and PRG, it's a beautiful all of the above question. Those are your respiratory groups, and they are located at the level of your pons in your brain, which is very, very deep. Your pons and medulla are very deep here. And like I said, whoever you believe built us pretty smart. And of course, there are peripheral and central chemoreceptors, and the main chemical that they're detecting is carbon dioxide. Hey, how many times did I say carbon dioxide? Let's see how many people answer oxygen. All righty. Maybe I should just fail you if you answer oxygen. How scary is that? No, let's not do that. All right. Now, this is what air is made out of. And if you look at oxygen, there's not a lot of it. It's only like 21%. There's also water vapor there as well. Just so that you know, like when you're breathing air, it's not all oxygen. If I filled the entire room with oxygen, we'd be blind by the end of the hour, because oxygen is really, really hardcore. You don't need to know these partial pressures. You don't need to know that. Carbon dioxide, no need to know. Ooh, iron lung, which is called the hyperbaric chamber. That's nice to know. So I think we hit up. Oh, let's just talk about this real quick, because I don't think I talked about this when we talked about blood. This is your red blood cell. It looks like a Cheerio, and it's anucleated, meaning it has no nucleus. But what does it have in the middle? It has hemoglobin. And if you look at hemoglobin, it's a coiled protein, and you could see it's like, it looks like there's chairs. Here's a chair, there's another chair, there's another chair. So this is where oxygen and carbon dioxide and glucose and other things sit. So oxyhemoglobin is when hemoglobin gets attached to oxygen. So we look at your hemoglobin in your blood, because that's what carries oxygen. Okay, and also carries carbon dioxide as well. And then also carries buffers. It also carries proteins. It also carries sugar. That's why, let's say for example, this is like a car, right? And has 4 seats. And I keep on telling my my physician, which I always do. I've been good. I haven't been eating bad things. Well, we can take your hemoglobin A1C, and I could count how many times the glucose sits in the last 90 days has been sitting in this car. So just own up to your physician when they ask you, hey, how's your diet? Just own up. I just say horrendous. I ate a cheesesteak right before I even came here. I just own up because they're going to find that out on the labs. So a glycosylated hemoglobin or hemoglobin A1C is when glucose sits on this hemoglobin molecule. Just wanted to add that in there. Nice to know. And also connects you to the, remember, because we study all of these things in separate chapters, but in real life, they're all connected. So let's now look at our objectives and then ask ourselves, did we meet all our objectives? And you could watch these videos as well. They have some really nice things. This one is a dead link. Don't worry about it. But can you look up oxygen transport on YouTube? Yeah, you can. But I think the other videos are sufficient. So did we talk about the structure of the respiratory system? Yep. We know all the parts and players and how they, did we talk about respiratory gas exchange? How things go in and out, right? Did we talk about oxygen and carbon dioxide and how they get transported around in our hemoglobin? Yep, we did. Let us now look at real quick if there's any other things in the lesson or task that we need to look at. Again, another dead link, but we already kind of know how cellular respiration goes. Oxygen plus glucose into your mitochondria yields ATP. And look, the electron transport chain, that is in your mitochondria. Glycolysis, or the breakdown of glucose, right? And the Krebs TCA cycle, which creates ATP. So you could look up those. But let's look up the case study for this week, see if there's anything weird or interesting. Nah, just answer the questions. They look pretty straightforward, and there are not too many of them. And again, due next week. So other than that, looks good. Let's look at a discussion so I can give you some hints. Now, some of you, this is what I noticed on discussions. Some of you are trying to write a book report. Please don't do that. I'll read it all. But others, you guys write like the most superficial thing in the world. You go to like 195 words, go 200 to 250. And again, you know, read my comments, because even if I give you full credit, the comments are there so you can build your professional writing. So for example, technology is now lung capacity, even using your iPhone, research, yada, yada. And also for everyone that I replied to or looked at, or you guys were good so far. Remember, try to pick something, you know, try to pick sources that are, if we're talking about technology, like 2019, 2020. And telemedicine, how's this? Telemedicine now is big. It's now the main thing because of COVID. So you could talk about that now, how, you know, being separated from your physician. I think I've seen my physician way more in the last 6 months than I do typically, because if pre-COVID, I get to my physician when I want to. Now they can harass me via, did I use the word harass? Well, they're always now checking up on me online. So I can't run away from it because they're in my face. And here's the cool thing. If you look at from the perspective of both the patient and the doctor gets to charge the patient a nominal fee, gets to see the patient more, right? And the patient gets to be updated on their meds more and updated on their health. So it benefits everybody all around. So if you're looking for a silver lining on COVID, that's telemedicine, and technology is really, really awesome. And now for all of my doctors, I now have a portal just like you guys, I can check up on my meds. I could check up. I can do little instant messages to my doctor. Like my gout meds aren't working. I instant messaged my doctor just not even 12 hours ago. The nurse called me back and said, "Hey, your new enhanced prescription is at Walgreens." I shot a message to Walgreens and go, "Hey, can you deliver it?" And I go, "Yeah, we can have it at your house by 2 o'clock." Now, typically, I'd have to go to the doctor, I'd have to go to Walgreens, I'd have to do all of that. But just imagine if I was in a rural atmosphere or if I couldn't get around. So you could talk about things like that on those advantages and related to modern things like COVID. So, I forgot to stop.